Hello everyone, you're extremely welcome to our fourth webinar in the series. My name is Marie Kilduff. I'm the Interim Director of the National Clinical Leadership Centre for Nursing and Midwifery, the Office of the Nursing and Midwifery Services Director in the HSC. As I said, this is our fourth webinar and it's entitled Nursing and Midwifery Clinical Leadership During COVID-19, Sharing the Learning from Public Health Nursing Services. I'm delighted to introduce our panel today, which consists of Mr. Neil Dunne, Director of Public Health Nursing, Dublin South City, Ms. Katherine O Sullivan, Public Health Nurse, Team Leader, Kerry Twilight Nursing Services, Ms. Neve Martin, Community Registered General Nurse in Dublin North Central CH09, Ms. Sharon Boyle, Assistant Director of Public Health Nursing, Dublin South West. And I'd also like to introduce my colleague, Dr. Clare Lewis, Deputy Chief Nursing Officer, Department of Health. And Clare is going to be taking notes throughout the webinar and will present the key findings at the end. So without further ado, I'm delighted to introduce our panel, and I'm going to start with Mr. Neil Dunne. Neil, you're extremely welcome here today. And as I said, Neil is a Director of Public Health Nursing in Dublin South City. And Neil, my first question to you is, and it's really just to set the context, I'd really like you to talk to us about your role as Director of Public Health Nursing, even before COVID, just to give us a sense of what the role involves.
Hi Marie, thank you very much. Yes, I'm very much a Director of Public Health Nursing working out of Dublin South City, and I've only recently changed role in relation to COVID response team clinical lead. But the background to public health nursing, I'm part of a geographical area for public health nursing of about 190,000 population for Dublin South City. And it's quite a diverse range of nursing services across the community and public. Historically, public health nursing was kind of an amalgamation of what we called community midwifery services and the district nursing services. And about the 1960s, it was kind of amalgamated into what we now call the modern day public health nursing service. That includes public health nurses who are trained in public health nursing with a qualification, community registered general nurses and healthcare assistants as part of it. But obviously the workforce has grown a lot bigger over the years with different types of specialist nurses within the force as well. And we kind of offer primary, secondary and tertiary care to population across the populations that we work with. Public health nurses have a population caseload, and for us it's Dublin South City. So that population caseload could be inner city population with all the challenges of living in an inner city population, out to kind of like the suburbs, Rathfarnham, Terranure, Rathgar, and all the demands of nursing required for that, which can be older persons focused sometimes. So there's a real diverse cradle to grave type of service that we do. And we're both curative and preventative in our role. We work with child health, and we, under the Nurture programme, we work kind of development screening assessment for child health with our public health nurses. We also do school screening. We do vaccinations, primary, secondary vaccinations in schools. We also offer school screening, hearing and vision. And we also offer a clinical nursing service in the community, as said before, things like wound care, post-hospital discharge for people, care of older people, care of specialist groups, care of complex pediatric cases in the community with children maybe with life-limiting diseases or complex care needs. So it's right across cradle to grave services that we offer this. And I work as a Director of Public Health Nursing, and under me there is the Assistant Directors of Public Health Nursing, who then very line manage the public health nursing workforce, which again, as I said before, is public health nurses, community RGNs, and generally healthcare assistants as part of that team.
And Neil, just listening to you there, it sounds like an extremely busy service and very, very diverse. I suppose I'm interested to know, what was the impact of COVID? And again, we're currently in the second wave. So if you could talk to me about the impact of COVID-19 on your role, your team and the service.
Yes, COVID really started to take an impact with us from about February of 2020 this year. And I suppose what first came to mind was the risk and the priority for our own staff in relation to COVID and their exposure to COVID in the different clinical scenarios in which they're working. So you had many staff in health centres, and health centres can be new, as in primary care builds, or they can be older health centres. So each geographical area offers a different challenge in relation to the risk for our staff and in relation to that. We also then had to look at prioritisation of our public health nursing service. What was the key things that we needed to deliver within the community for public health nursing, with clinical care or postnatal visiting of people was important as within that. And then there were also staff who perhaps were vulnerable, who had health problems, and they needed to come forward with their own risks in relation to possibility of picking up COVID infection. And so we needed to listen to them very carefully about their healthcare needs or their close family healthcare needs and work with them in relation to that. And then the demands started to come in relation to the setting up of new services and new pathways in relation to COVID. So testing was really important, static testing or setting up testing sites. And basically my entire school immunisation team got involved with the setting up a testing site, 2 testing sites within Dublin, providing static testing sites for COVID for people who were referred in by primary care, by GPs in for testing in relation to that. And that service had to move from, we're normally a 5-day service with a weekend covering service. We had to move to 7 days, 12 hours a day in relation to these things. So my staff were brilliant and very flexible in relation to moving into greater hours with that. We also had to set up community test assessment hubs for COVID, and Sharon will probably talk about that later on, has the setup of that. But those community assessment hubs were referrals of COVID or presumptive COVID clients or patients into an area to be assessed for a period of time to decide whether they could be managed at home, whether they needed to go to an isolation centre, or whether they needed to go to acute hospital if their symptoms were particularly bad. And we used an early warning score with that. And it was working very closely with our GP colleagues in setting up that service, and also with our senior management in setting up that new pathway. There was also the request also in relation to my own staff in relation to where I felt the real crisis was, Marie, and that was within older people, vulnerable older people in settings such as long-term care, private nursing homes. And I found that there was quite a large demand on me from senior management to look at supporting nursing homes within my area. So then I had to encourage staff to volunteer and look at their gifts, their strengths, their clinical strengths, and begin to be intentional about asking them to support me in supporting nursing homes. A very personal story was my own daughter, who's a health and social care professional, and she was reallocated to a community nursing unit. And on her first shift, a 12-hour shift for her, she encountered 2 deaths within the nursing home on the people that she was working with. And the difficulty was that family weren't allowed in at the time, and it was very difficult for her. So the night that she came home, she was very upset, and she described the experience of the deaths of these 2 older people. And whereas before I had been trying to work with management about giving staff, for the first time I had somebody in my family who had experienced the real difficulty and the real crisis of COVID in the nursing home, in the community. And I was really stirred by compassion to really look at that, to see how I could help more, how I could help my staff be assigned better and work with that, because I knew this is where the real crisis was, and began to work very closely with senior management about looking to see how I could assign both my staff and my senior staff, my assistant directors. Because sometimes in some of the nursing homes, the entire nursing management structure was out on COVID leave. And so it was important for me to identify some of my senior nurses to be able to go into those situations and provide nursing support and management support for those nursing homes that were in a real crisis at the time.
And Neil, what I'm really hearing there is the responsiveness was really huge in terms of how you responded to the evolving crisis and managed it, and then really heard from a personal perspective, what it was really like for staff trying to manage situations when they're dealing with people dying without their families, which is, we've heard this in the last few webinars as well, which is really, really difficult. Neil, you've talked about some changes and a lot of change in terms of COVID and the impact on your service. Is there any key changes that you've really identified that you'd like to talk about?
Yeah, I think one of the real changes was a real integration for the first time. And I'll talk about it perhaps maybe in 2 ways. There was an integration within primary care itself. I had to work really closely with my colleague directors of public health nursing. So Community Health Organisation 7 is made up of 4 community care areas, and that's 4 directors of public health nursing, and we always work collegially and work together from a strategic point of view. But we were called almost into the same kind of emergency action room and had to start working very closely. So what Sharon was doing in Community Care Area 4 and in Dublin, Kildare, West Wicklow, and those places suddenly had to work very closely with my other colleagues in relation to responding to the crisis. But not only that, we started to work very closely with our health and social care professional leaderships as well. So OTs and physios, speech and language, they were getting involved in being reallocated into static testing sites. We had physios working with us in the assessment hubs. So we worked very closely with our health and social care professionals and really valued their willingness to change and adapt and work in a different way themselves within that. And then we also had to work with senior management within primary care. Every day there was a crisis meeting, and we looked to see how we might develop services, develop the testing hubs, develop the assessments, how staff were redeployed, what risks were involved. We had to work very closely, and I think senior management also got to work with us very closely and realise how important we were to them in relation to that. We also got to work with national HSC people in relation to developing structures and care pathways. So many of my colleagues, including myself, were involved in setting up of structures around how to set up testing teams and how to set up assessment hubs properly with the right scope of practice for nursing and within that. So it was really interesting working with senior HSE people at national level to try and develop these new pathways.
So there was immense changes, really, and what I'm really hearing, Neil, here is the implementation of Sláinte Care in a sense, in terms of how you've worked with different disciplines, the kind of collaboration between acutes and community, and I suppose it's just really giving us a glimpse of the future and how things will look. Neil, it's just a really good opportunity to have you here today, and thank you for joining the panel. As a very senior member of public health nursing, in your current position and in your seconded position, there will be a lot of public health nurses, community RGNs and other staff from the community, such as health and social care staff, listening to this webinar today. Is there any message you'd like to give to them, given that you're here now and you will have these people listening? Is there anything you'd like to say to them?
Yes, I'd just like to say that we are a very creative and adaptive clinical workforce. And for my nursing colleagues, a clinical nursing workforce. How we've managed to respond to COVID in this crisis has made me so proud of our profession and of my health and social care professional colleagues, how they've relocated to do very challenging work, from working on night duty in a nursing home, through to static testing on a site where you're working out of very limited conditions and buildings to provide swabbing for people has been amazing. Just that adaptation, that willingness to embrace change, to move to assistive technology, video conferencing, teaching people to care for themselves better and be more independent, self-care. We've really had to move away from creating dependency with our patients, particularly those with ulcers or chronic wounds, and get them to take responsibility for caring for themselves. And it's almost like a real paradigm shift for us in nursing to really encourage our clients and our patients to be self-caring and independent and take responsibility for their wounds and for their care. It's been really, really interesting within that. So yes, that creativity, that dynamism that's there, and to embrace Sláinte Care is really important for us. That Department of Health drive of policy in relation to bringing care to the point of people within the community. We want to lay a good foundation for Sláinte Care. We want to be a clinical workforce that is responsive and reflexive to the needs of a changing Ireland going forward.
Neil, thank you very much. I don't think you could have put that better, and thank you so much for your presentation, answering the questions, and for your final messages.
Thank you, Marie. It was a pleasure talking to you this morning.
Thank you. So I'm now going to move on to our second panellist, Ms. Katherine O Sullivan, Public Health Nurse, Team Leader, Kerry Twilight Nursing Services. Katherine, you're very welcome here today, and I'm really looking forward to hearing about this service. So could you tell us initially, how did the Twilight Nursing Service come about, Katherine?
Oh, thank you for inviting me, Marie. The Twilight service, it came about as a direct response to the onset of COVID-19 in Ireland earlier this year. And I suppose as increasing reports of people, as Neil referred to earlier, people dying alone in hospitals without their families around them, we saw an opportunity to provide an enhanced nursing service for end-of-life care to COVID-positive clients in their own homes. And so this was community nursing based initiative, was requested by the management, HSE, and our Director of Public Health Nursing started it in March this year. So our team of community registered general nurses and public health nurses were redeployed from our regular whole-time staff, equivalent staff here in Kerry, and they were voluntarily redeployed, very happy to come on board for the team, and they work 12-hour shifts over 7 days in the community. So in Kerry, we are very lucky that we work very closely already with specialist palliative care services. So we would have a lot of shared care, changing syringe drivers and so on. And there was a gap in service provision identified, I suppose, in that from 5 p.m. when the service was finished until 11 p.m. at night when the Irish Cancer Society nurses would come on board, there was a gap in service there for families and for clients. I guess our hope would be that the Twilight nursing team would somewhat help to bridge that gap in service.
And Katherine, it's such an important service because we have heard so much about people dying without their families and being alone without their families during the pandemic. So I'm just interested to know, how did the service expand to all palliative care patients?
Well, I suppose in Kerry, firstly, we're very lucky earlier in the year that the numbers of people with COVID-19 were quite low, and we actually had very few COVID-positive palliative clients in the community. But restricted visiting in University Hospital Kerry meant that families were having very limited access to their loved ones at end of life. So it was decided then to expand the service to offer to all palliative clients, and that would be people with malignant and non-malignant conditions, to allow them to offer them the choice really of being in their own homes for end-of-life care. So we had great support from our public health nursing colleagues and the specialist palliative team, and also from the social care team. So we don't have any home care support workers on our team at present due to staff shortages, but we've had excellent support from the team out working, in people's homes. So it was decided to run the service as on a trial basis, a pilot service for 3 months, just to see how we get on from the end of June, and then to review it at the end of September.
And again, Katherine, it's another example of great collaboration between disciplines in terms of how you speak about the different disciplines coming together to make this happen. Could you tell us how the outcomes have been, or what have the results shown so far?
Well, by the end of September, we had supported over 50 clients and their families in end-of-life care at home. And that actually amounted to over 300 nursing contacts over that time. So at the end of the 3 months, we sent out a little survey, a small questionnaire to the bereaved families just to get some feedback. And actually the feedback was overwhelmingly positive. People were so happy with the extra nursing care, with all the extra support and reassurance that we were able to give. And they felt it really added to the service that's there already. And then we had a lot of very positive verbal feedback from our public health nursing colleagues and from the palliative team also, who felt it really supported people at home, and they were very happy with sharing the workload as well. So I suppose the only slight negative from our point of view is that we are quite a small team, and Kerry has a very large geographical area, so we weren't able to offer the service all over the county. And I suppose like place like South Kerry, very remote, very long distances for people to travel, so it just wasn't feasible. There literally isn't enough of it. But I actually feel that maybe those rural areas are where the service is actually most wanted, because people that have lived in places all their lives just want want to be in their own homes at the end of their lives.
And that's so important, Katherine, isn't
Mm-hmm.
it, to give everybody their wish. I suppose, unfortunately, as we know, we're living in the second wave of COVID-19, and you've continued the service. Could you talk to me about what the future holds for the Kerry Twilight Nursing Service?
Well, I suppose we're really hopeful that we'd have a commitment to continue on the service. And so it needs dedicated funding, really. So at present, we're compiling a business case to look for ring-fenced funding. And our hope would be to build the team. We'd like a larger team with more nursing staff and also some home care support workers. It's just a better use of resources, really. And I suppose the other important thing with working in the palliative area is the recruitment of appropriate staff, or people that are happy to work in that palliative area. And the other very important thing is that people would have training and ongoing education, and that we'd support that ongoing learning as well going forward. And I suppose eventually it's not available it's not in Ireland yet, but the hospice at home would be our eventual goal. That's a multidisciplinary team of doctors, nurses, OT, physios, home care support workers, maybe alternative practitioners, all dedicated to looking after people at home at end of life. But that's in the future, hopefully.
Well, yeah. Hopefully your experience and what you've presented and your evidence, Katherine, will help to support that initiative coming to Ireland, because it's so important, as you've said. And just well done to yourself and your colleagues on this initiative. It's so important, and it's great to get the family feedback as well, that it's been working so well. So thank you, Katherine, for coming today and presenting.
Thank you very much. Thank you.
So we're now going to move on to our third panellist, Miss Neve Martin. And Neve, as I said, is a community RGN working in Dublin North Central, CH09. Neve, you're very welcome today.
Thanks very much. How are you?
Good, Neve, and thank you for joining us. I'm really interested to hear, Neve, what was the impact of COVID-19 on your role as a community RGN?
Yeah, so I think Neil and Katherine both have talked about changes that have occurred. So physically, I suppose the wearing of PPE, and it was funny, there was times in the lashings of rain where you'd be under your boot donning on PPE, and just things like that were different. We'd have to carry out risk assessments prior to every house call or clinic call. And as Neil has talked about, the P1 system, the priority basis in terms of us delivering care to just high clinical need clients and patients and vulnerable adults, So it was kind of the physical changes and kind of what our workday entailed changed a good bit,
It sounds like, Neve, as you described that, I have an image of you there under the car trying to get changed and that, so there was challenges. I'm sure that wasn't the only challenge. Would you like to tell us a little bit more about the other challenges that you faced with the impact of COVID-19?
So we were told, it was trying to deliver your care in 15 minutes or less, and one of the best things about community care is allowing people the freedom of opening up regarding any health concern in the comfort of their own home. So you're not just kind of having this verbal assessment, you're actually observing people in their own environment, how they're coping physically and mentally. So to carry out an assessment in 15 minutes kind of goes against the grain in the community. I think you kind of have to allow people to lead to get a better comprehensive assessment. So that was challenging. You kind of had to complete a bit before you go out. You'd carry out a home visit, and then following it, you'd have to complete another kind of phone call if there was areas that you kind of hadn't discussed or needed more detail on. Services stopped as well. Unfortunately, respite, daycare centres, I should say, and some Meals on Wheels services. So we had to kind of figure out what was happening in the area. Some community resources that came to the fore. The community services in Sanctuary were phenomenal. We linked in closely with them. We linked in asking them to give support to people who were particularly at risk of social isolation. Community GA teams were phenomenal. They'd do shopping for clients and for patients all around. So that kind of restriction of services makes you kind of fear for people who would be kind of go under the radar in these kind of situations. So they were some of the challenges that were faced for me anyway.
And Neve, it's really good to hear about the collaboration with other public services as well, such as the Garda Síochána, etc., and to kind of pull in all the resources to try and optimise the care delivered to your patients in the community. Can I ask you, could you tell us about the positive changes from your experience of COVID-19?
Yeah, so Neil actually talked about how he had to collaborate a lot with a lot of management and people of his level. And the same happened in a very smaller level within nursing. In our health centre alone, we decided to meet a lot more, have team meetings at a socially distanced way as much as we could. And this meant, I suppose, community nursing can be quite solitary, but you felt supported when you were linking in every day to ensure that everyone was okay. And there was a great kind of camaraderie as well. So people who, as Neil had said, voiced concerns about vulnerability, whether themselves or at home, were assigned possibly more desk duty assignments as opposed to face-to-face clinical care. So that teamwork really came to the fore when we were faced with a crisis. And then I suppose the other positive we talked about was kind of empowering patients. When this all kicked off for us in February, March, we didn't know what it was going to look like. We didn't know whether we would be redeployed. We had to look at patients who possibly we could upskill in terms of self-care. So empowering them to take ownership over their own healthcare, from medication administration to possibly catheter care, catheter flushes and minor wound care. So that was a real positive in terms of, as nurses, you nearly come and you take over everything because you want to mind people and you want to look after them. But I think learning from this, it's definitely one of the things that is a positive thing of allowing patients to look after themselves.
So Neve, just as I'm listening to you there in relation to presenting on your role as a community RGM, particularly during COVID, I'm really hearing all the different leadership competencies coming out. I mean, you've got the empowerment of your patients, advocacy for yourself on behalf of them and their families, communication skills are key, teamwork, all of the leadership, and so well done to you and your team and all of that. I suppose I'm just going to ask you a question now that I do ask frequently, but I suppose it's kind of the magic wand question. If we had a magic wand and COVID was to disappear in the morning, and we're all wishing for that, what changes would you think are important to maintain that you've seen in the service over the last few months that you would keep if COVID was to go tomorrow?
Yeah, well, I suppose, allowing patients to take responsibility over their own healthcare, as Neil has said, and if we become more of a shared care resource in the community, where we can be there as a support for people who are taking ownership over their own health need, and then that might free up services for things that Katherine has alluded to. So that would be a massive positive from COVID, and relinquishing the kind of role of the nurse of taking over the care as opposed to sharing the care with the patient. I've also become more efficient, I think, at communication techniques when it comes to deciphering patient need. This came to the fore when I suppose we were conscious that hospital discharges doesn't always demand a home visit, and that was deciphered through assessment over the phone. Previously, you might have asked, what kind of family support, or do you have good family support? And the client would always say, oh yeah, they're phenomenal. But I suppose you had to go into more detail to really find out what the situation at home was. So you'd ask more pressing questions like, well, how often do they visit? Is it daily? Is it weekly? And what kind of support did they provide? So you got a much greater picture over the phone as to the client needs and what kind of supports they were. So definitely has changed how I've worked and hopefully will work in the future.
Thank you so much, Neve, and thank you for taking the time to present today. Our fourth panellist is Ms. Sharon Boyle, Assistant Director of Public Health Nursing in Dublin South West. Sharon, you're very welcome to the panel today, and we're delighted to have you present. Sharon, could you tell us about your experience of setting up a community assessment hub in one of your local healthcare centres? Because this is key to COVID, and we've been hearing so much about community assessment hubs, and your submission, it was just really one of the submissions that we felt people need to hear about this initiative.
Thank you, Marie. So I was delegated with the task of setting up a community assessment hub. The community assessment hubs were centres where patients who were COVID positive or presumptive positive were symptomatic and they couldn't see their GPs and they needed to be assessed by a doctor. So they came to the community assessment hub, and then there were 3 pathways for them to take, either to go home. If they couldn't self-isolate at home, we'd refer them then to an isolation unit, or we'd refer them on to hospital. So the assessment hub was staffed by nurses, admin, we had security, we had doctors, GPs, physios came on board, and I was one of the clinical leads. So as part of my role then as well, I was to, first of all, find the staff. So we asked staff to volunteer and come and work with us, which was great. I was delegated the task of developing the standard operating procedure for all the hubs within the CHO. And as part of that, then I had to read all of the guidance that was out there on the HSE websites and HPSC about the national operating procedure as well, and put it together so that staff were aware of how it would operate and what they were to do. I think this was a benefit to me because it was a very daunting challenge. It was tiring. But again, the team that came on board, they volunteered and they were great. And so I used all their skills to help me with this challenging task. We had to organise training. A lot of training had to take place. So while I was reconfiguring the health centre to be effectively what was like a triage centre, a mini A&E, if you want, for the words, yeah, the staff were training and then they came on board, and then we collectively had a vision and we looked to see how it would work, and together then we got it working.
So Sharon, just as I'm listening to you there, I'm imagining how challenging that was. I'm just thinking of other panelists on previous webinars and our panelists today, and everyone was in a situation of an evolving crisis, so to speak, and in a situation of a lot of uncertainty. And I'm just imagining you reading all the information and trying to do SOPs and trying to manage everybody at the same time in a situation that was new. The community assessment hubs were new, and you were dealing with patients coming in with a virus that very little was known about at the time. What I'm really wondering is, Sharon, I'm imagining it was very challenging. As a leader, what was your greatest challenge at that time?
Yeah, Marie, as you said, it was a very challenging time. And I think my biggest challenge was learning how to contain the fears of the staff. So we had nurses, doctors, physios, security staff, admin, cleaning staff, all working in the hub. And so they all had different fears. I too was fearful. I didn't know what to expect. And so I was reading, as you say, I was reading all the information. It was overwhelming for the staff, all this information coming on. So I felt that if I gave them the information and we discussed it and we discussed how to minimize the risk, and I got them to tell me what they were afraid of, what was their biggest fear, got them to talk through their fears. And then like that, there was information there from the HSE, from HPSC, guiding us on how to minimize our risks. And so they were then informed, they were empowered with this information then, and it helped them to see, well, look, we are doing everything we can. We have the PPE, we have this SOP, which helps us with the flow, the organize, and everybody has a job, everybody knows what they're doing. And so if there was anything that was lacking or missing, the team then, they gave their opinions, and we then made changes if they were needed, you know, to improve how it was going to work. And so that then helped, I think, with the fears. It helped with my fears as well, you know, because it was a very frightening time.
And I can only imagine how hard it was, Sharon. What I'm really hearing though is an authentic leader who's honest in terms of how they're feeling, which, as we know, leadership is so much about being authentic and being honest, and just to role model that, so at least the staff felt comfortable to be able to admit how they felt as well. Just as you're talking there, Sharon, I'm wondering, how are the staff doing?
Yeah, so like that, we used reflection and feedback throughout this journey, and because everybody had fears at different times as well, so they all went through different stages. And so the staff have reported that they call it the Black Monday, the 16th of March, and that was they say they feel was their bravest moment. Some of them feel the fact that they faced a fear, they were so frightened. Some of them were physically shaking, and now they all feel a lot stronger. They feel that they could actually challenge and do anything now, because they feel that they got through that Monday, coming into work when schools were shut and they didn't know what was happening, but again, through feedback, they gave me feedback, I gave them feedback. They were given a lot of information and the freedom to ask questions, and they feel a lot stronger now, they're saying.
So Sharon, just as you're talking about the experience there and the experience of the staff and the huge learning, I'm just wondering, as a leader, you're managing this unit and you're continuing to do that. From the learning, what advice would you give to future nurse leaders who are, contemplating or maybe end up in this situation? And from your experience, what would you say to them?
So I would encourage them to not shy away from taking a challenge, because it is extremely rewarding as a leader. It's quite lonely as a manager, but you do need your team. And as a leader of a team, you're not always the one that's in front. You kind of have to move between the dance floor and the balcony, as I learned in the Future Leaders program with yourselves and the RCSI, and that, sometimes other team members take the lead and you have to take a step back. Giving feedback and information empowers your team, and it also helps them then to make decisions, and help you with making your decisions as well. But again, it can be a lonely experience as a leader. So, it's important then to use your team, to support you and to not shy away from it, because it is extremely rewarding to be able to walk away at the end of it and leave your team there to continue on. Sleepless nights, a lot of sleepless nights, but like that, yeah, I can walk away like the hub is running now today and I'm here. You don't need to be there every day, once you've done the groundwork, and once you have a fantastic team like I do.
And Sharon, thank you very much for that. I mean, they're really good tips for people listening. And the sign of a really good leader is somebody who can walk away and everything continues as if they're there, and that's obviously happening today. So, well done to you on this initiative and all the work you've put into it.
Thank you very much. It was lovely talking to you.
So thank you to all of our panelists. I'm delighted to hand over to Dr. Clare Lewis now. And during the webinar, Clare has been taking notes on everybody's points and she's going to present the key findings. Thank you, Clare.
Thank you, Marie, and thank you to all of our speakers. I am continually inspired by the creativity and leadership demonstrated. And I think our speakers have really articulated the key areas of Sláinte care and, the future direction. But just in terms of the key points, Neil very eloquently demonstrated the diversity of the public health nursing role in terms of the caring for across the lifespan of care, and also focusing on population health and meeting the needs of the local population. And in terms of his role, his leadership role, it was really very much balancing existing services and responding to COVID, and the mobilisation of nursing services to continue to provide the essential care, but also to staff testing centres, move away from a 5-day to a 7-day service, to staff community assessment hubs, and moving into residential care settings, which would be a completely new environment. And identifying the importance of supporting the needs of staff when they were moving into those areas. But it was really, it was really positive to hear the level of integration that we actually saw, and integration with primary care and health and social care professionals, and also at senior management level, at regional and national level, to support the structures for testing centres and for community assessment hubs, and develop care pathways. And I think Neil demonstrated very, very well the creativity and flexibility of nursing, how adaptable they have been in responding to COVID, and how the workforce will provide that architecture for Sanctuary care and moving forward. And just moving on to Katherine and the Twilight nursing services, it was fabulous to hear how an enhanced nursing service has supported people, their patients and their families at end of life, and it's really responding to the needs of delivering care closer to home and within the home, not just for patients with cancer, but for non-malignant disease. And the positive experience that families have had from accessing this service, which will stay with them, and help them in dealing with their grief, but also the importance of looking at the scalability and sustainability in rural areas. So you're thinking about access and coverage, and the staffing and skill mix to support this model going forward. So moving towards hospice at home, and the importance of having a multidisciplinary team response. And Neve, when she spoke of the response as a community RGN, the importance of triaging appropriately to be able to identify those who required those essential services, but also as well changing the way that they practice. So they had a blended approach. So it was a home visit, but obviously with infection control, there was an aspect of virtual health assessments that were undertaken as well. And also looking at integration with non-healthcare services. So that big piece around the community call to support those patients who were at risk of social isolation. So drawing in on GEA and the local Gardaí, and that collaborative leadership that came through that. But what I think was really important was that empowerment of patients. So in a crisis, we've actually had a positive effect in terms of upskilling patients to be able to manage their own health in areas such as medication, catheter care, minor wound care, and the ownership of their own health, and how we look at that into the future. So having a shared care resource, so patients and families are partners in their decisions about their own health and determine the care that they require as a collective. And then just finally, Sharon, in setting up the community assessment hubs, I think it was really important how they distilled that guidance around COVID to operationalise it at local level, and also the staffing and skill mix that was required, and the training needs, and reconfiguring the environment. So you're going into basically like a mini emergency department in the community. What was important was that collaborative leadership. So you're drawing upon the knowledge and skills of the team, but you also needed to identify the anxiety experienced by staff to be able to support them, and communication was key. So it was looking at what were the risks and how did we mitigate against those, so you could support staff and reduce their level of anxiety. And I'd just like to thank all of our speakers today. It's been incredibly interesting, and I'm sure our audience will be inspired by the response that has been demonstrated in the community. I feel very proud. Thank you.
Thank you, Claire, and I echo your sentiments. Thank you so much to Neil, to Katherine, Neve and Sharon. I think you were excellent today, and it's wonderful to hear of your experiences, and I'm sure our listeners will really appreciate the time that you've put into this and for coming today to present on your roles. I'd like to thank everybody who's listening to the webinar today. Our next webinar will be held on the 25th of November 2020, Nursing and Midwifery Clinical Leadership during COVID-19, sharing the learning from acute nursing services. Thank you.